Thank you for the opportunity to present the case. My name is Diogo Garcia. I'm a general and trauma surgeon here in São Paulo. I work at the University 9 de Julho, and this case is from Hospital Salvalus. It's a private hospital in São Paulo. So the case is a case of a female patient. She's 30-year-old. The case was at 23 of June of last year at 10:30 a.m. She was brought to Hospital Monte Magno. It's another private hospital from the same insurance company. She was a victim of a motorcycle was struck. She was at the motorcycle. So the pre-hospital care transferred her to a private hospital. We don't have a trauma system like other countries do here in Brazil. So a patient that has insurance can either be brought to a public hospital or a private hospital. That call is just made by the people that are at the scene, by the pre-hospital. So she was transferred to a private hospital in São Paulo. It's a small hospital. They just have orthopedic service and emergency care. So she was taken to that hospital, and I don't have the exact data from the first care, just the things that were sent to our hospital by a report. So she was seen first by the orthopedic surgeon. She had an open fracture of the left leg of the tibia, and the orthopedic surgeon called the emergency physician. He made the diagnosis of hemopneumothorax and did a tube thoracostomy. At the time, she had a BP, a blood pressure of 96/52. Her heart rate was 126. She received 1 unit of red fact cells, and they asked for a transfer to a higher level hospital, and the highest level hospital in the private network is Hospital Salvalus. Hospital Salvalus is a hospital that has about 800 beds, ICU, intensive care, 24-hour radiology studies, blood bank, and it's the highest level in the insurance company. So about 3 hours and a half after first care, at 2 p.m. or 14 hours, as you say here in Brazil, she was received at Hospital Salvalus. At the first care, she had a clear airway. She was with a 90% saturation of oxygen with a high flow oxygen mask. She had a right chest tube. It didn't have any air leaks, just a bloody output. And the patient referred, she was feeling like she was drowning. She had a very severe chest pain on the right side. Her blood pressure was 110/80, and her heart rate was 74. She did a fast exam that was positive. She had a Glasgow Coma scale of 15, and she had a left open tibial fracture, Gustilo-Anderson 2, but her neurovascular examination of the leg was normal. So the emergency physician asked for a CT scan, a whole body CT scan, started pain control for the chest pain, asked for labs, and sent the patient to the ICU. The head and neck CT had no findings related to trauma, and the chest, and just let me change the so the abdominal CT scan, we can see liver injury, severe liver injury. Unfortunately, the patient said she was allergic to the contrast, so the doctor at the ER did the CT scan without contrast, but she has, we can see, not perfectly because of the absence of contrast, but we can see a liver injury, some free fluid, and a kidney hematoma, maybe a kidney injury also. No fractures. So a liver lesion. We can know exactly the grade because we don't have contrast. We don't know if there's active bleeding also. And the chest CT. You can see a huge emphysema that goes all the way up to the neck. Her chest tube was misplaced, so after the CT scan, we repositioned the chest tube. Probably that's we can see that's a small hole of the chest tube outside of the chest. She had a good pulmonary expansion. It seems like the chest tube's going through the lung, but if you see the CT scans going through the I don't know if the seizure is the right word in English, but it doesn't go through the lung. We see all the time, but it seems like it's going through the lung, but it's not. So we didn't have any air leaks, anything like that. And the bone CT, we can see she had also some rib fractures. So this 3 fractures, she had fractures in 2 points and another fracture here on the front. So after that, she was sent to the ICU for pain control for the chest, and for as she was stable, we tried to do a non-operative management, but at night at 23 or 11 p.m., she got worse. She had 84/40 and 136 heart rate. She had a worsening in her level of conscience, Glasgow Coma scale of 13, and also she had worsening in the respiratory parameters, a saturation of 89% with a high flow oxygen. So we started our massive transfusion protocol. She received first 2 red blood packs, 2 plasmas, and 1 platelet. She was intubated and sent to laparotomy. During laparotomy, and the fixation of the tibia too. So she had a grade 3 hepatic trauma with active bleeding. She had a heteroperitoneal hematoma zone 2. It was explored. We found a renal trauma with no active bleeding. So we did a liver packing and closed with a vac. It's not, we use the Baker technique because we don't have the commercial vac for abdominal closure. So we did the Barker technique. When she came to the OR, she had a pH of 7.16, a BIC of 15.7. I don't have any other information on the blood gases because that's those are the ones that are written in the anesthetic chart. She had a hemoglobin of 7.8. In our hospital, normal is about 12. She had received 2 blood packs, 2 plasmas, and 1 platelet. At that time, her BP was 86/42, and she had a heart rate of 126. So the first question, and I don't know if Valeria is going to pull it up. Okay, thank you. Is how would you manage damage control resuscitation in this case, in the OR now? So would you use the 1-1-1 transfusion with blood packs and plasma and platelets, whole blood? Would you use prothrombotic complex, fibrinogen, and platelets? If you don't have a massive transfusion protocol, what would you do? And if you have another options, I think Dr. Johnson, if you can manage the questions.
Dr. Calderon, your comment, sir?
Yes, thank you, Gary. Just a small comment for a beginning. When the patient arrived to the new hospital, was transferred, he should have a new chest X-ray before moving him to the CT scan, yes, for precautions. Maybe he had a new pneumothorax that was not trained enough. Yes, a new chest X-ray, and after that we will see. So, well, we can see the patient is still hypotensive in spite of a good and appropriate stay in the ICU, a good laparotomy. We have no. It seems that we don't have any more findings where he should be bleeding. I would do a question, Dr. Garcia. What did you find in the spleen? Because in the CT scan, I see some fluid around the spleen.
You're muted, Dr. Garcia.
Yeah, just about the X-ray, I didn't put it clear, but the fast exam actually was an e-fast, so we checked for pneumothorax and other things with the ultrasound, so we don't have to do chest X-rays at the emergency room. And she didn't have anything in the spleen. The fluid that was around the spleen and also in the pelvis was just from the liver. She had a very bad liver injury, and
okay.
The heteroperitoneal hematoma was small compared to the liver injury.
Okay, thank you. So by now, well, she already had a new, a very good done laparotomy. Unfortunately, she's allergic to the contrast, so maybe interventional radiology and angiogram is not a tool available or suitable for her. So we just have to continue that resuscitation on her. I choose to use the 1-1-1 because it's the more readily available weapon in almost everywhere. But we just sometimes it's very difficult for some places to have a prothrombotic complex available. But we can use either the 1-1-1 or whole blood, whatever we have available. This time we should just continue resuscitation on this lady. Well, thank you.
Thank you, Dr. Calderon. Let's go to Israel, Dr. Vasquez.
Thank you, Doctor. Yeah, I also agree with Dr. Calderon. I will go with the 1-1-1 resuscitation protocol, which is the one that we use here in our hospital. We're talking about high energy trauma. When we have these situations of suspected IV or iod allergies, and in this kind of patient, we would decide to intubate the patient and to give her steroids before the injection of contrast, and then to decide if it can be treated in the OR or it can be treated conservatively in the ICU or by radiological intervention. That is my comment, Doctor.
Thank you, Dr. Vasquez. Let's go to India. Dr. Rao.
As the lung has already expanded on the CT scan, as we have seen, there is no need of any X-ray again. And he may have to be resuscitated with whole blood and should be taken for surgery immediately and as soon as possible. A laparotomy is essential and should be shifted to the theaters for necessary surgical intervention. Thank you.
Thank you, sir. Let's go Sarasota, Dr. Onchak.
Yeah, so in this case, you know, when this lady came to the hospital on transfer, and she had been in your ICU stable for about 12 or 13 hours and then got hypotensive. So she was not acidotic and her body temperature was presumed normal. She was well perfused for that time. So it suggests that really the cause of the bleeding was surgical bleeding, that a blood vessel opened up, and So I believe now you're in the operating room or out of the operating room. So at first I thought that you'd gone to the operating room, finished the laparotomy, then went back to the ICU. So you're out of the operating room, and then she's still bleeding. So it's not a matter of she's cold and acidotic. So I think Dr. Vasquez's comment is a good one. Give her steroids and then see if the interventional radiologist can find a single point of bleeding that you can stop. If not, if you can't do that, then I think she's still actively bleeding. Then I would take her back to the operating room, pack the liver securely, and get control of the bleeding. I would also add tranexamic acid to the. You chose option A in Iraq. I would use option B because we don't have platelets there, but either would be okay. And then something to inhibit fibrinolysis. But I think in this case, this is surgical cause of bleeding that has not been controlled, and I think you need to try and find that.
Thank you very much, sir. Sao Paulo, Dr. Calais.
Yes, I here in Hospital das Clínicas we start with 111 for reposition volemic, and I have a doubt because you have show us CT without contrast. If you can see the CT with the contrast, you can see blush, and sometimes you can make embolization in these patients early, then avoid damage control surgery. And sometimes you can see if there is blending, injury of the kidney, and can avoid exploration of the kidney, because sometimes when you go to exploration of the kidney, you open the fascia and can make damage to the kidney. So I want to know why you don't make contrast in these patients, Diogo.
No, I agree, Dr. Kule. I think that's probably what happened. She had a arterial bleeding from the liver that was not seen in the CT because we didn't have contrast. So we took her to the operating room. We did the packing, and now she's getting worse again. And probably because the arterial bleeding was not resolved with the packing. So, and we didn't do the contrast specifically because the radiologist decided not to do it, but I think that the best option would be to have done it in the first place. But it's hard to decide when you're going to intubate a patient that had a severe allergic reaction to contrast, because she was stable at the moment of the CT scan. So we would have to intubate her, do the CT scan with the contrast. Now we know that would be helpful, but before she had that complication, maybe if she didn't have anything, that would be a little aggressive for just doing a CT scan. So that was one of the points. We didn't do it because she had a past of a very severe allergic reaction with contrast. But I agree, if we saw a blush, we would do the packing and then do an embolization. But we didn't have that information at the time.
Does that answer your question, Dr. Calais? Okay. We'll go to Dr. Supa in Bangkok.
In this case, I would consider using IR and angiographic embolization anyway, because from the non-contrast CT, she had deep parenchymal injury of the right lobe liver, and she had signs of continuous bleeding. Even after packing in the ICU, she continued to bleed. I think at this point, IR would be very helpful in this case. I would ask the IR, the radiologist, to maybe give her some steroid before giving her contrast media, because the first priority is to stop the bleeding, and the reaction to the contrast media, I think it can be dealt with after. And the ideal place for her in my hospital would be the hybrid OR, where we could perform packing, more packing at the liver, and call IR people to try to selectively embolize the bleeding vessel that is deep in the liver parenchyma. And the second point, I would not explore the right kidney if there was no active bleeding or expansion of the hematoma, because you had pre-op CT scan already, and there was no like big hematoma around the kidney. And that's it. Thank you.
Thank you very much, sir. I see Dr. Mahoney from Boston. Sir, will you want to comment or you participated? There you go. How you doing, sir?
My comments will be limited since I signed on late, so I did not hear the whole case. Just regarding what resuscitation, we do a one-to-one here. Simply because we don't have access to the whole blood, it's not part of our protocol. I will intermittently give cryo if the patient's not responding how I think they should. We also do not have TEG here, so I will add the cryo with that. And I want to support the honorary doctorate to Dr. Gary Johnson for all the hard work he's doing for all of us. Thank you.
Thank you, Dr. Mahoney. As I said before, folks, I appreciate the promotion, but in this lifetime, I haven't ascended to that lofty height. So, but anyway, any other comments before we return to Dr. Garcia? Okay.
This is Kyle Remick. My first time dialing in, so I don't know anybody, but I'm a U.S. trauma surgeon. Spent 25 years in the military, and I'm now working in Bethesda, Maryland, at the medical school, the military medical school. Great presentation so far. And the one comment I had is based on what you described, 2 and 2 resuscitation in the operating room is exceedingly low for what the picture of the CT looked like and for what you described in the operating room for resuscitation. And I'm not surprised that the pH is 716 post-op, given that low resuscitation. This patient needs more one-to-one resuscitation in the ICU, and continued rewarming, if not warm already. The other comments I had was, if you believe that you've done everything you can surgically, with packing, you don't have any options for, doing any kind of finger fracture and trying to get down and control bleeding directly in the operating room, then I think you are at the point where you make the decision to go to IR, regardless of the contrast allergy. I wouldn't give steroids to a trauma patient acutely, but I would, but I do know, an intubated patient that has a severe reaction, I can put on epi, and, thwart that reaction pretty much. So I think there's, as a last resort, if you're going to use IR, I think it's a reasonable decision as well. And I think, so far it looks like a good presentation, a good course of events, doing what you can do for this patient. Over. Thanks.
Thank you, Dr. Remick. Thank you for joining us and welcome to the conference. So we'll go ahead and go back to Dr. Garcia for a continuation.
Okay, I know that 221 seems a little, but she's a very small patient, and she received more at the ICU after surgery. So, but I still think that's not plenty. She should have had a little bit more. So after that, as we didn't have the CT scan with contrast, we decided to take her back to the operating room. She received resuscitation with more blood. Let me see if I can. She received, going the wrong way. So we gave her another laparotomy. She already had the sternal fixation. So she received 4 packs of red blood cells. And we did the hemostasis with 2 doses of Beriplex and 2 doses of hemocompletan, 1 platelet. We did that we don't have a tag or a rotin in our service, but we are starting to use prothrombinic complex to try to use less transfusion of plasma and precipitate. And at laparotomy, she did have an active bleeding from the liver. So we tried to find a arterial bleeding, but there was no arterial bleeding. So we just did a repack and closed the abdomen again with a vac. I saw at the chat that somebody asked, why would you use vac for a bleeding patient? We do use vac for patients with damage control laparotomy in every case. I know that some places they don't use vac on the first operation. I don't know if they still use like something like a Bogota bag or other stuff, but we use a vac dressing in all cases. So after that, she went back to the ICU. And she went back to the ICU. They corrected the coagulopathy, the hypothermia, and all the other problems. At third postoperative day, she went back to the OR for another surgery. There was no active bleeding, so we did drain the liver and did the definitive closure of the abdomen. At the fifth postoperative day after the first laparotomy, she was sedated. She didn't have any vasopressors. Her BP was 11/7, a heart rate of 98. She was still in mechanical ventilation with medium to high levels of ventilation with a PEEP of 10, O2 aspiration fracture of 40%, and her saturation was 98%. She didn't have any other organ failures. She had a good renal output, urinary output. Her hemoglobin levels were 9.2, platelets 180, that's normal. And now that she's stable and apparently the abdominal trauma is solved, the question is, how would you manage the broken ribs? So she was still in mechanical ventilation, and she had 3 fractures with 2 points and another fracture down here. She was sedated with opioids and.
Okay, so Dr. Calais, your comment, sir?
Yes, I know what Diogo think about it, but it's very clear. They are usually working with this, but for us in our hospital, you use it to control the pain and supportive care. You don't have usually materials to fixation the ribs. In this situation, you can see the ribs is 3 ribs. I saw Diogo with two, yes, 3 ribs. I believe can wait and observe. And I want to know how is the lung in this situation. In the 4th postoperative day, she has a contusion, and then she was traching. She has need something different. Because usually in these practice you have associations of pulmonary contusion.
Yeah, the X-rays didn't show any pulmonary contusions, and the chest drain was with blood, but about 100, between 100 and 200 milliliters a day. So for the X-ray, we didn't do another CT scan, but the X-rays that they do every day in the ICU didn't show any pulmonary contusions.
Okay, I believe at this moment, I think it's important to wait, try to extubation the patient and see what's happening. If she continues to have pain or have some distress, chest distress, so maybe I think about to put external fixation.
Thank you very much, Dr. Calais. Let's go to Dr. Donnelly.
Thank you, Gary. I wasn't present at the initial presentation, so I would think I should not comment on this. The only thing I would add is about the question on the rib fixation, that the idea would be to fix them with titanium plates. If you don't have titanium plates, I think you should, if ICU situation is better, so it seems, I would fix some of the coastal fractures either on the side, on the lateral side, some of them. Thank you.
Thank you, sir. Let's go to Boston. Dr. Mahoney, your comment, sir?
I'm glad she's doing better. Regarding the rib fixation, there's always a lot of debate about when they should be fixed or not, and there's not a legacy belief about that. The East guideline stated that anybody with the flail, the benefit has been shown in patients with flail segment, and based on this 3D reconstruction, she has that flail segment. At our facility, we would plate this. We base it on a revised Denver criteria, and so based on this, she would meet criteria. The need for mechanical ventilation, flail segment, multiple displaced rib fractures, there's bicortical displacement here. So it's great that she's doing well on the ventilator, but with positive pressure ventilation, it may be a false positive. So therefore, we would advocate for plating those, and we would plate across the each those ribs. I can't tell which rib it is, but she'd probably need both. She needs the flail segment stabilized, and probably each one above and below to stabilize. It does look like there's enough room posteriorly to get at least 3 centimeters stabilization in the medial aspect of the posterior aspect of the ribs. So we would advocate for rib plating if it's availability. Thank you.
Thank you, Dr. Mahoney. Let's go to India, to Dr. Rao.
As she is improving clinically and she is stable, she won't require any other surgical intervention for the ribs as per se. And so she should be continued on this conservative treatment, pain control, and then look for another CT scan if necessary, and 2D echocardiograms to rule out any other associated mediastinal injuries. And then she can be kept safe for this chest part of the problem itself. And she may be treated conservatively. Thank you.
Thank you, sir. Bangkok, Dr. Supa.
Theoretically, this patient would be benefit from replating because she had a failed segment and she's been on respiratory care for several days. But my answer to this patient was pain control and supportive care, like Dr. Colette, because this patient just had damage control surgery to save her life from bad liver injury. And in this, the patient like this, I wouldn't add a second operation that may enhance inflammation or infection for this patient. If she had like isolated chest injury and required mechanical ventilation, I would think about replating. But she had multiple trauma and multiple problems. And this problem, I think we could get by with pain control and supportive care at this point. So I wouldn't add a second operation for this lady. And in my institution, we have replating. I usually consult the ortho guy to fix the ribs for us.
Thank you very much, Dr. Supa. Sarasota, Dr. Untrack, your comments, please.
Yeah, so I guess now we're 2 days after the last laparotomy where the bleeding has been stopped, and it's a flail segment, but it's low in the chest, just adjacent to the liver that was injured. So, you know, then the issue is 2 days after the last operation, she's on the ventilator, oxygenating well, but is she not weanable? I'm not sure that Dr. Garcia mentioned whether she's weanable or not. And is pain the issue?
She was coming out soon.
Sorry, sir?
It didn't seem like she was coming out soon from the ventilator.
Okay, and then the other issue is pain control. So, you know, my inclination would be to treat this like a typical flail chest. And by the way, was that segment actively flailing on physical exam? Because it's above the liver, so, and there's very little lung under that segment. But you know, so I think it might be a little different from if it were higher on the chest. But regardless, my inclination would be to treat it like for at least for the time being. And I think Dr. Supa's comments were very wise reasons he gave for wanting to defer, at least temporarily. So, that would be my inclination to treat her with positive pressure ventilation, stabilize the flail segment, be sure that the liver is not going to start bleeding again, rebleed a second time. And I think that would be the wise way. Although I know in this case, based on another case that you presented several years ago, and the way you titled this presentation, I'm pretty sure I know what you did, and that it worked out well. But I was impressed by Dr. Supa's reasoning in this case.
Thank you very much, sir. Let's go to Dr. Calderon.
As the patient is more stable now, she has a flail segment, but those respiratory numbers don't look so bad at all. Maybe I can just wait with pain control, supportive care, try to wean off the patient from the ventilator, try to extubate her. If we succeed in extubate the patient with good respiratory mechanics, we just can do the pain control and supportive care. But as you said, if the patient doesn't improve from the respiratory standpoint, she would be a good candidate for the refixation. Now, to mention, in my setting, in my environment, we don't do the fixation. We leave it for the cardiothoracic surgeons. They do the fixation, and we have the supplies for that. Well, thank you. That's it.
Thank you, sir. Israel, Dr. Vasquez.
Yes, thank you, doctor. Also in my hospital, we don't do fixation of the ribs, but I know that in a hospital 30 minutes from here they do fixation for everyone. So what we do here is to in intercostal block and high doses of painkillers, physiotherapy, and about the drainage. I think if we already passed the window of the pneumothorax and the fluid that we're receiving is less than 200, we already will be able to remove this drainage to avoid another infection. That's it, doctor.
Thank you, sir. Any comments before we return to Dr. Garcia? Okay, back to you, Dr. Garcia. Check your mic, sir.
Sorry. So the option was to do a rib fixation, and we did a preoperative 3D planning with a 3D printer. Actually, this is the model that we printed. Unfortunately, during the operation, someone dropped it on the floor, so we lost a few of the ribs of the second segment here. So unfortunately, I didn't have the picture of the whole model before the surgery, and we fixed all the ribs. It's 8, 9, 10, and it's 7, 8, 9, 10, and 7, 8, 9, and the 10th rib. So we still have here the 2 places of the rib. She had a severe chest injury with exposure of the pleura here. So we did that. And one thing that we did that's different from the previous case is that I had presented the case before that we did the model with a company, and the model with the company would cost about $1,000 here in Brazil, between $800 and $1,000 for a company to do all the planning and all the things that they do. And this one we did a 3D model made at home. It's not actually at home, it's in my office. We use just free software. We use the cost of the material for this model is about $20. We use a plastics called PLA, and the model was printed in 21 hours. So we have to decide 1 or 2 days before surgery to start doing the model. So actually, every time I have a case that probably is going to need fixation, I usually do a model to be ready if it's going to be used. So just to show how we did it, the first thing you need to do is to convert the CT scan, the DICOM file, to a 3D object. We usually use a free software. There's a free software from Brazil. It's called Salvalus. You can download it in your computer. It's good for some simple cases. Now we are using another software that's called 3D Slicer. It's also free, but has some more options for doing the 3D model. After doing that, you work on the model on software to prepare for printer, like Mesh Mixer is another free software. And the third thing, you can print it on your desktop printer at home or in your office. To have an idea about prices, how would it cost to do such a thing? You can buy a 3D printer on Amazon, about $250 to $600. The difference between prices is because of the difference of the size of the printer. So bigger printer, like needed for doing a rib cage big model, would be about $600. 1 kilogram of a material is about between $20 and $50, depends on the quality of the material. And for this model, I used 250 grams. So it's about $5 to $12 if you buy the simple one or the best PLA that you can use. Actually, I can show that's really. So here I have software. Just to show how easy it is. So you just a second, because how you do it. I have previously loaded the CT scan of this patient. So here we have the CT scan that I just showed you. You just need to choose what part of the CT scan you want to use. Here you can track if you want more or less. So if you're doing a bone reconstruction, like this case, it's easier. For doing other stuff like liver or other organs, it's a little harder. And in a few seconds, you can have the 3D model. So it's here, so you can see the fracture ribs. And then you just need a software to take out all the stuff that you don't need, like cut in half, take out the sternum, take out the other side, take out the scapula. And then you would go to another software to print it. And this is actually my office. This was in the beginning of the project. So I have now I have 5 printers in my office because we have a lab that's studying. So here we are printing an arm immobilization, and this is the one that I use to print the big models. So it's a printer from this one. You can either you can also print like pig implants and stuff like that. We can use that because we don't have the right place for sterilization, stuff like that, but it would be a possibility to also print specific implants for the patient. So this is some other applications that we're doing. We're using for orthopedic cases. We're using for teaching students. We're working with also people from physiotherapy to develop, I forgot the name of this, so stuff for correcting insoles. Insoles, yeah, that's it. Insoles. We can print it in flexible material. We are using for teaching students, so we can print a video laryngoscope with some cheap material and some cameras that you can buy also on the internet. So I think that the last question would be, What's your opinion on 3D printing in medical field? So if Valeria can just put the question. Just to see the experience of the group. But it's a technology that's getting cheaper, it's getting more accessible, and the idea of presenting this in this case is that some people still think that 3D printing is like rocket science, but you can just start doing it, and I think that's a place for preoperative planning for rib fixation and for other cases too. And I think it's a really good option for teaching and for students and residents, especially for teaching them anatomy and stuff like that.
Yeah, so, you know, and I recall the case from several years ago, and the benefit to the 3D printing that I remember from that first case is that you can prepare all of the hardware ahead of time. You can have all the metal bent and sterilized, and it shortens the operation by about, I don't know, 50%. So I think that's the real advantage to the 3D printer. And so it's good for that. But sorry?
No, that was just someone with an open mic. Go ahead.
Okay. All right. So, but my concern is, and that's always the case with the new technology, there are issues coming up with when laparoscopic surgery was first being used, and the robotic surgery, and you know, and the issue in this case is, you know, how to make the choice between going ahead with the rib fixation versus the traditional management initially to do the, you know, paraspinal block or local blocks and positive pressure ventilation for a few days, you know, and there's always the caution to be sure that the decision is driven by the clinical needs of the patient and not the enthusiasm for the new technology. But I think it's very innovative. It's, you know, it's a terrific technology. It's going to be used a lot. It's inexpensive, you know, $600 for that huge printer, I think is impressive. So I think that's the issue, that we have to, you know, just be sure that, you know, it's used appropriately, and there's not the sort of conflict of interest between the enthusiasm for new technology versus the direct clinical needs of the patient. And I have one other question about, you mentioned the Baker method or Parker method for the wound vac. If you can just explain what that is, because I've been in a lot of places where there's lack of resources, and we devised our own wound vacuum dressings that work great. But I'd be interested to know, I haven't heard those eponyms, if you can just explain those. Thank you.
Thank you. Thank you very much, sir. Israel, Dr. Vasquez.
Listen, I just have to add that this was a really nice presentation, and with this technology, the sky is the limit. We don't have I hope someday I will be able to work with that, and just to congratulate you, doctor. It's really interesting.
Thank you, Dr. Vasquez. Dr. Donnelly.
Impressive and excellent. Congratulations, Dr. Diogo Garcia. Thanks.
Thank you, Dr. Donnelly. Let's go to India, Dr. Rao.
Congratulations, you have done a good job. But many of our patients will go without any internal fixation. Many, not many, most of them. And unless there is a plial segment that persists, we don't use this type of fixations as at all. And also, we don't have this latest technology of using these 3D pictures and all. And it's very expensive in our view. And in many parts of our country, we don't use this. Thank you for showing all this new technology.
Thank you, sir. Dr. Supa, your final comments, please.
Very interesting case and very good management you did to the patient. I don't have an access to 3D printing in my department, but in my hospital, plastic surgeons, they use a lot of this stuff to plan their complex reconstruction. and very interesting to see someone uses this technology in planning with plating. Thank you very much for showing us.
Thank you, Dr. Soup. Let's go to Peru, Dr. Calderon.
Very interesting. I have a question for Dr. Garcia. Did you pay yourself for the 3D printing, or did the hospital pay for that? What was who paid for the printing?
Dr. Garcia, muted, sir. There we go. Good.
I was just trying to reach for the mic. First, addressing the question about innovation. Dr. Collet knows me better than you all, and he knows I'm really driven to innovation, and I know I'm biased, and so we are trying to find answers to see if it's a good option or not. For rib fixation, I think this case we had a flail. It's a discussion to always just if you have a benefit from clinical flails or radiological flails. In this case, we didn't have a clinical flail with segments moving, but we do have a radiologic flail. So I think the patient would benefit for sure if she had only the flail chest. But as Dr. Super said, it was a very severely injured patient. So maybe fixing the ribs, not fixing the ribs and treating her with a rector spinal block or something like that would be the safest way to go. About the payment, that's the big problem with 3D printing. So the problem that we did 5 cases with that company, and we just presented the paper in the World Trauma Congress. We had a reduction time in surgery about 40 minutes because we do the bending of the plate prior to the surgery. So everything you have to model and bend, you can do a day before the surgery. So it showed a 40 minutes reduction in time for median time for surgery. So that would could pay for costs, but in this case, I paid for the costs myself. So we are doing, I'm doing it as a research project at the university, but this hospital is not from the university. So at the university covered the costs for the studies. But as this case was not the case for the university, I had to pay it for myself. So I have the university for covering the printers and the material, but not specifically for this case. So I just had to pay like the $20, $30 for the material, and also all the time that I had to do the model. It's always on my free time. But the idea to show this is if you don't have access to a 3D printing fancy lab in your hospital, maybe if you're interested in technology, you can start it with a very low funding or a very low investment from the institution with some simpler printers, and to show it's working, and then go for another more advanced technology. Did you answer your question, Dr. Calderon?
Yes, thank you for the answer, and I really apologize for the question, but I know in Peru we have both settings, public hospitals and private practice. And yes, 3D printing is a reality, and it's a very interesting tool for the pre-operatory planning. The limitation is financial or institutional. In the public hospitals, our government is hesitant to pay or to invest in these new tools. It's going to take another 20 years before they are convinced themselves that these tools are very useful and they save lives. Yep. And in the private practice, it's not really different. Sometimes we have to argue with the insurance to approve to something that is going to be useful for the patient. And yes, this was a very interesting tool, the 3D printing. It helps you not only for the preoperatory planning, especially in orthopedic cases, in spinal cases, also for educational purposes. And I'm dedicated to medical education lately, yes. And I tell you, Dr. Garcia, in my early years, sometimes I have to pay out of pocket myself to some supplies to have the cases done, because in public hospitals, sometimes we don't have some supplies, and that the things has to be done. The patient has to be done, and I needed a training. Sometimes I had to pay that from my pocket too. Okay, thank you for the opportunity.
Thank you, Dr. Calderon. So, Paulo, Dr. Calais, your final comments, please.
First, congratulations for Diogo. Nice to see you again, Diogo. It's a long time. I know what you think about the hip fixation. I agree with you. I know it's very important, but it's very difficult to do in several hospitals. In the use 3D printer, in the university, I have the 3D printer. The telemedicine will have, and it was useful for make pieces for students who can see all the wall, the chest wall, what to put the chest tube, and it's very easy to make a model, and you can take the students to see what's happened. For surgery, I believe it's for bone injuries, bone repair is very important, because you can estimate it, all the pieces you need to correct the injury. So it's very important, because you can use no more than less. And I know the great problem here is that the way that in Peru is the same. When I need to do something different, sometime in the hospital, you have to pay it. You can usually to do for the patients, but you have to pay, because nobody will pay. So if you need, sometimes you have to pay. It's very difficult to us to make things, to study, to try to make, if you don't have this in mind. So congratulations, Diogo, and I know you have very nice experience with rib fixation, and thank you for the presentation. Thank you to share us your experience.
Thank you, Dr. Calais. Do we have any additional comments before I turn it over to Dr. I'm sorry, go ahead, Dr. Intl.
Yes, I just wanted to ask Dr. Garcia the question about the way he innovates the wound vac, the Baker method or Parker method, if you can explain that.
Yeah, it's a technique that was described really early in the damage control. It's I don't specific. I'll just check to see. It's from Europe. I don't know specifically what place did it, but it's the simple way that we always do the technique. You just use a plastic film that's perforated, and then some surgical sponges over it, and you put a chest tube or a nasogastric tube over the sponges and an adhesive film. So that's the way everybody does it, but it was first described as the Baker technique.
Oh, okay, right. That's the way I would do it in places where they don't have the technology, and it works very well. But I didn't know those eponyms. Thank you, sir.
Thank you, Dr. Intl. Any other comments before we go to Dr. Martos for the closing comments? Okay, it's all yours, Dr. Martos.
So, Diogo, congratulations for the great presentation. I remember you presenting data and a demonstration, a case report at the American College of Surgeons meeting 3 or 4 years ago, maybe 5. We are with COVID lose track about the meetings, and it was very well received. And I know your efforts in developing new technology, new solutions, and specifically in this case, I think what happened going to be the same with the laparoscopy in the 90s, right? I remember laparoscopy became a reality, but a lot of hospitals or administrators are still kind of thinking about the cost of the equipment or the trocars, etc. But with good data, good information, good publications, now everybody does laparoscopy. I think that you need to keep showing the results of your procedures. At some point, publish a lot the cost savings, and mainly, I truly believe this is very beneficial for the patient. Can decrease operating room time, and at the end is better for patients. So congratulations for a great case. Thanks for presenting to us. That's what you want, to keep this group united. and discussing how to treat trauma patients around the globe with different tools, different equipments, with the research that you have available in our regions. That's why sometimes we do some things from Brazil, some presentation from the United States, from Super, from Thailand and other places. That's the idea, to all of us to learn with each other the different ways to do the same thing, treat the patient, trauma patient. Thank you very much. Hope we can meet you all next week. And again, if you want CMEs, remember, have 24 hours to claim your CMEs at the Nurse Miami website. Thank you very much. Diogo, good, congratulations, good case. See you all. Bye.